for Jhansi city. He is very renowned interventional cardiologist of Jhansi and very soft spoken and available for each of her. So he is going to present the next session, cardiovascular protection with Finneron. So I invite Dr. NIRDESH JAIN for delivering.
Colleagues and my seniors, and before I will start my talk, many of the things already have been explained by my dear colleague Anshul and Sanger sir, and my part is now very much reduced, so I don't need to work hard now. We all know that this chronic kidney disease, diabetes and heart failure, these three things share the common risk factors. These three things share the common risk factor, and common risk factors are, we all know that obesity, inflammation and the vascular disease. If we consider that the big circle, the CKD, in the CKD around the 42 to 53% patient develop heart failure. If we consider only diabetes, so in the diabetic around 40% goes into the CKD, and in diabetes 25 to 40% patient develop into heart failure. So these circles are interchangeable because these three things share common pathology. The largest trial data that I have studied in 67,227 patients by the Lawson et al. If we see the patient of all new onset heart failure, that means the patient who have developed heart failure and diagnosed heart failure within 1 year. So in these patients, around 32% patients did not have any CKD or diabetes. But the most of the patient, as in the previous slide, in the 40% patient heart failure have CKD. And 16% only have a CKD as well as diabetes. So that is the largest data that I could read. And this bar diagram shows patients without diabetes and that have an incidence per 100 per year of developing heart failure and death is 8.6%, and that goes very high when the patient develops both diabetes and the CKD, and that is around the 6 times, 52.3%. If we consider only death, cardiovascular death, so this incidence per 100 years is only 5.5%. When this deadly combo, diabetes and the CKD, and this incidence increases 20%. So both disease have enormous value hazards for developing heart failure as well as cardiovascular death. As sir already said, the albuminuria is a surrogate marker for chronic inflammation, and because the risk factors are common: hypertension, diabetes, obesity, inflammation. So the chronic inflammation leads to the cardiovascular dysfunction and the activation of renin-angiotensin system, sympathetic activation, as well as the mineralocorticoid overactivation. What does the mineralocorticoid overactivation do? It increases the afferent arterial pressure and increase the efferent arterial pressure and decrease afferent pressure. So that's the albuminuria is increases, and damage to the glomerular filtration, ultimately albuminuria increases. So albuminuria is just a surrogate, not a surrogate marker. Now it has come up with the more emphasis. If we see, if there is a urine albumin creatinine ratio decrease or maintain this level, if we see the overall survival by changing in this category, if we, as sir said, that if we achieve the UACR decrease more than 30% the baseline, it will reduce, it will increase our survival. If we see the first line in this Kaplan-Meier, the survival become around 65% overall survival. If we are not able to achieve this target, or it is increasing UACR over the time, so the survival is decreased. So patient with more than 30% decrease in the UACR had the highest overall survival. If we consider cardiovascular event-free survival, so again, and those who are not able to achieve this, the median time to composite cardiac vascular outcome was highest for patient with more than 30% decrease in the UACR. The only three trial that I have come to know, Figaro DKD and Fidelio DKD, and the pooled analysis of both trial was done by Fidelity Analysis. So it is a pre-specified analysis. Fidelity is not a trial. The data of the two trial was combined and again considered for studied. So Fidelity, when both data is combined, so it was studied for the in patient with atherosclerotic cardiovascular disease subset of patient, and those patients initially have heart failure. Those patients initially was enrolled having LVH, and the results was taken up for the overall mortality. The primary outcome was cardiovascular death, hospitalization, heart failure, non-fatal MI, and non-fatal strokes. So whenever I will be talking about these four things will be considered. So this is the trial Figaro. The average age was about 64 years, and most of the patients in around 40% patient when they were enrolled in this study having the cardiovascular disease history, and 7.8% was having the heart failure. So when the patient were enrolled in this trial, only the 8% patient had heart failure. Then interestingly, we see that the 100% patient were already receiving the RAS inhibitor, and other glucose lowering therapy were also receiving the most of the patient. And SGLT2 inhibitor was also, because this is also a newer molecule, not new, but that time was studied, this was published in 2021. So around 8% patient were already receiving SGLT2 inhibitor. So in this trial, the finerenone significantly reduced the risk of primary cardiovascular outcome by 13%. If we see the number needed to treat after 3.5 years was 47, although it is not very good number, but because it is only primary cardiovascular outcome. But when we talking to the hospitalization for the heart failure, so it reduces around 29% of the incidence of hospitalization for heart failure. So whenever in the cardiology, it is very difficult to get any drug to make sense in reducing the mortality overall. It is very difficult. Only the few drugs we all know that could reduce the mortality. So in the primary outcome, this is the soft target that we include to make the value significant. But it reduces by 29%. If we see the cardiovascular, it did not reduce. But overall primary outcome was reduced by 13%. And that is primarily driven by the rate of hospitalization heart failure. Finerenone significantly reduced the risk of new onset of heart failure by 32%. So this is the important, in new patients, the incidence is decreased by 32%. If we see, the lines are separating very early. Within 3 months, they will start separating. So early benefit of starting finerenone in patients, these patients who have been seen. When these data were analyzed in atherosclerotic cardiovascular disease, the definition for ASVD was taken in 3 terms, and those patients having MI, have had MI, and those have gone coronary vascularization or have proven angiography, or patients who have developed ischemic stroke of peripheral arterial disease, or the by the carotid artery intimal thickness, the patient diagnosed with the atherosclerotic cardiovascular disease. So at the time of enrollment, around 45% were having the atherosclerotic cardiovascular disease. This is a significant number. Around half of the patients were already having atherosclerotic cardiovascular disease when they were enrolled in the study. The cardiovascular benefit of finerenone was consistent with irrespective of atherosclerotic cardiovascular history. If we see the first, when we see the composite outcome, with the history, the patient having the composite outcome reduction was 17%. And when we see the without a history of atherosclerosis, that was not significant. If we taken the overall, it was significant. So those patients who had atherosclerotic cardiovascular disease at the enrollment, their hazard ratio was 8.83. That means 17% reduction in their primary outcome events. But those who did not have the atherosclerotic cardiovascular disease at the enrollment, they did not show much significance. But if we take in overall, there is significance. In the initial, I told at the enrollment, around 8% patient had heart failure. In 7.7% in Fidelio DKD and 7.8% in Figaro DKD trial. Time to total heart hospitalization for heart failure was reduced by 21% in Fidelity subgroup analysis, and the time to cardiovascular death and total heart failure hospitalization 80% reduced risk of cardiovascular death and total heart failure hospitalization in the Finron group. So if we see the both risk of total hospitalization for heart failure is reduced by 21%. If we consider risk of cardiovascular death and total, then it is 18% reduced. Another subgroup analysis, those patients who had the enrollment LVH by echo, and in patient who had the LVH at the baseline, patient with LVH at the baseline, it is very important because those LVH is developed because of the hypertension. So those patients who are hypertensive and had LVH at the baseline, Finron is used. This marks 28% reduction in their cumulative incidence of cardiovascular event. Those patients who did not have the LVH at the baseline, there was although it is significant, but the less reduction in their cumulative incidence of cardiovascular outcome. So those patients have had LVH, they had the substantial marked effect in their reduction in the cumulative incidence of their cardiovascular outcome. If we see this plot, patient time to heart failure hospitalization by LVH status at the baseline. So there is a 66% reduction in the cumulative incidence of cardiovascular outcome. If we see both the lines, they have separated by the marked difference. The Finron in the Finron group and in comparison to placebo, 66% reduction in the cumulative incidence of cardiovascular outcome. So in my those patients who are already hypertensive, they have LVS, they must be having this DKD, so they are benefited more. Finron demonstrated significantly on treatment reduction in the incidence of all-cause and cardiovascular mortality. What does it mean by the on treatment? It means that those patients who continue to have treatment, they were benefited more. And those patients who were taken as an intention to treat analysis at the beginning, when they were assigned to the drug group and one in the placebo, they did not found to have the significant reduction in the sudden cardiac death. So those having the on treatment, that means the patient has taken into consideration till the last dose, he has taken 1 month back. So those patients, those who continue to have their treatment, they were benefited more rather than those were taken as an intentionally treated analysis. Other benefit, one more trial has come, Find Heart study, and that has shown the other benefits. It is all known that the kidney composite endpoint is reduced by this drug. Heart failure hospitalization is reduced by this drug. And in this trial, the cardiovascular death or heart failure hospitalization is reduced by this drug. And another important thing is the new onset AF is reduced by this drug significantly in 17% reduction. If we consider in the nutshell all the MRAs and steroid MRAs, spironolactone, epinephrine and Finron. So in the heart failure, we know that it is recommended as a class in class 3-4 heart failure reduce ejection fraction to increase survival, manage edema and reduce need for heart failure hospitalization. It is also used for the hypertension as an add-on or resistant hypertension, used for edema in patients of cirrhosis, used as a primary hyperaldosteronism for the short-term treatment. Epinephrine is used as mostly for the heart failure patients. It has less marked hypertensive effect, as already told by your colleague. And similarly, the epinephrine has a very small effect on the hypertension or blood reduction. So it is not used for the, particularly for hypertension, or the use has not come up. If we see the trials rails and for this heart failure FSS trials, and the data of Fidelio DKD and Figaro into that pooled analysis of Fidelity, and both the side effect we all know that. So the latest guideline in 2023, European Society of Hypertension, epinephrine is recommended for patients with type 2 diabetes, CKD, hypertension, and EGFR more than 25 ml, and provided the hyperkalemia potassium less than 5 to be present when we are starting. European Society of Cardiology has given us a class 1 label A after these 2 landmark trials to be used. So in the nutshell, this molecule is very good option for patient with heart failure with preserved ejection fraction, with heart failure with mildly reduced ejection fraction. Its trials are being done for its study in heart failure with reduced ejection fraction. So it is good drug for one more drug that come into the feather for heart failure with preserved ejection fraction. That presently we are having only the SGLT2 inhibitor. So it is another armamentarium that we can use in patient with the heart failure with preserved ejection fraction. So now we cannot say that we don't have any other drug for heart failure filled with preserved ejection fraction. So it is another drug that we have for heart failure with preserved ejection fraction that have the multiple benefit in like CKD production, CKD progression reduction. So presently in 2023 guideline has endorsed to be used for the heart failure with preserved ejection fraction and with mild reduced, because all the studies that have in the initial study, when the EF is less than 40%, they were excluded excluded from these 2 trials. So it is not used in heart failure with reduced ejection fraction. Although trials are going, that will come up by the end of the 2026 to more know about this molecule. Thank you.